and welcome to the ECIST podcast. My name's Jennifer Walker, and today we're joined by Angela and Graham from Leeds, but I'm going to let them talk a little bit more and introduce themselves before we get into the questions. So Graham, can I ask you to introduce yourself?
Yes, I'm Graham Sutton. I'm one of the elderly medicine consultants at St James's Hospital in Leeds, and I'm the clinical lead from the trust point of view for the Leeds Virtual Frailty Ward, which I suppose in NHS England new language, we are a hospital at home service, just to help people clarify what we're talking about today.
And Angela.
Hi, I'm Angela Gregson. As Graham said, I'm his opposite number in the Community Trust in Leeds NHS Community Trust Healthcare. I'm the clinical development lead. I'm a nurse by background.
Thank you so much both for joining us today and for talking about your virtual ward. Delighted to have you here. I'm going to jump straight into the questions if that's all right. And first of all, what were the steps that you took in setting up your virtual ward? Can you talk us through it and how you got to where you are?
Yeah, sure. I think one of the first things, so it was back in May 2019 when there was the sort of first concept that Leeds wanted to have this sort of service. And myself, Angela, and a project manager called Katie Smith, we were the sort of the team that were told get on and do it. So I think one of the first things I would say is that we had time to set this up. Katie was full time, 5 days a week, Angela 4 days a week, and myself 1 day a week. And it's really being able to talk to all the stakeholders that are going to be involved in that patient journey. So we started off with really just sitting down with a large piece of paper, lots of pens, and stakeholders who we thought were going to be needed, and trying to kind of map that patient journey. So we made sure that we would be talking to all the appropriate people from the start of referring all the way through to that time that the patient was discharged from our service, and who could possibly be needed along the way. And those meetings were pretty regular at the start. I think they were at least every 2 weeks, and we would report back to the steering group as to how we were getting on. But I think it was also important to talk, or if at that time in 2019 people were going to face-to-face meetings, so we went to see our colleagues in Bradford to get an idea of what they were doing. And I think it's trying to kind of just figure out, though, obviously the service in your area may be very different to what we do, maybe very different to what Bradford or the other kind of very well-established services around the country who have been going much longer than us. But it's trying to see what best fits you have and what sort of staff you have available to give to be able to kind of come up with that service. And I think we also sort of started, so Leeds is divided up into 13 neighbourhoods, and we decided to focus on admission avoidance by starting off in one of those 13 neighbourhoods, trying to get it roughly right in that area, and then relatively quickly go to a third of the city. And I think that is one of the most important things, is really to have a rollout plan and try and stick to it. And although, I mean, I must admit, I was quite worried when the COVID-19 pandemic hit, because obviously that could easily have sidelined us. But I think in spite of all of that and the challenges that came along in 2020, we were able to go citywide by the beginning of October 2020. And at that point, we also started to facilitate early transfer from elderly medicine wards and the emergency department to us there. But I think some of the other sort of important things along that way was really talking to potential referrers. So myself and Angela went to the GP meetings in November 2019 as we were about to start, right at the end of that month, to say we're coming to this neighbourhood soon, and this is our plan of rolling that out. And as we moved from area to area, as I say, because of the pandemic, we started to do more of these Teams invites, and Angela certainly did a lot of the legwork talking to GP practices to kind of nudge them to say, we are coming, please think about using our team. And I think, and understandably, I think with the ambulance service, we have had to sort of do a bit more education and meet with them on a regular basis, because Yorkshire Ambulance Service covers such a wide area, and if you have if a service is only for one area, then they may well be based a lot of the time in other areas of Yorkshire. So it will always other services that I've been involved with when I was clinical lead for our department, it can easily take 12-18 months before it really comes embedded in people's minds. So, but I think it is just keep on talking. And I think because obviously this was a bit of a sea change, that people were looking after more unwell people than they were used to, and it's ensuring that your clinical teams are happy and confident to look after those people. So there's a lot of education. Angela set up sort of regular clinical meetings so that we could try and iron out those kind of problems. And I think it is learning from issues, which I think we were very good at, and we have continued to be good at. And I think we do respond to concerns from whether or not it's the hospital-based consultants or registrars or the community teams to really try and improve our service. We're by no means perfect, but I think that's one of the because we work closely together as a leadership way, but also as a kind of a clinical team way. I think I'm very proud of what we've achieved. I don't know, Angela, if you want to chip in any more.
I think there's, I think you've probably said it all, Graham, but what I would say is that the way that Katie kept us on track from a project management perspective is that we started as a development group with all the required organisations represented on that group, from the Mental Health Trust, from the third sector to adult social care to the ambulance service, and critically the clinicians that were going to be developing the ward. So Graham from a geriatrician perspective, but we had the community matrons who were the key people out in the community who actually go and see the patients first, and so they helped us shape that clinical model, that clinical pathway, and as Graham says, we constantly take feedback from anywhere to continually improve the service. So once we'd developed it as far as we thought we could, then we move into implementation phase, as Graham described, with the first neighbourhood and then following on. And it was almost like Graham describes, it's like a plan, do, study, act kind of cycle. Each time you rolled out, you were listening, you were taking feedback, and they were all implementation phases from then on, really. So yeah, and I think the other people that we had critically on the team and development was pharmacy and the night care service in Leeds as well. So we had the data people, and we all split. Basically, we split into the development phase. We split into task and finish groups. So there were task and finish groups for the data and performance, for the clinical aspects, clinical training, for governance, for pharmacy. Each adult social care, each area that needed considering had a task and finish group that fed into the development group, which fed up to the steering group. So that's how it worked. And
I think, sorry to.
That's all right.
But in again, I think, and we also did. We have a respiratory virtual ward here in Leeds, so we used some of their standard operating procedures to develop our own. And I think even though they are very much in the background, they're on, our Leeds health pathways here, and we don't necessarily need to reference them a lot. But I think they form that sort of bedrock from a governance point of view. And I think we were very clear with GPs that the governance and the responsibility really did sit with the geriatricians, which I think helped alleviate some of their concerns. And one of the tips that we had from Bradford was also to make sure that you have a physical space to review people. So back in those when we started up, it was our frailty unit, which is now kind of transformed into same day emergency care. So we do, I think, right at the beginning, because again, this was as I said earlier, it was a sea change for the community teams, but it was also very different for some of the geriatricians. And I think having that physical space to help make sure that we could give blood transfusions, that we could get scans done, and also try, if the diagnosis was ever in doubt, that has been a useful kind of tool. I think overall we're using it less for diagnostic issues, because I think again people are just more comfortable and getting used to things. But I would certainly say whether or not one could. I think we've been a little bit slow, and there's no reason why we shouldn't do more of this, but actually doing more of the teams kind of consultations with the patients in the homes, which for some reason we don't do. But again, there's no reason why you can't.
And the GPs, I would just reiterate what Graham said, the GPs are always, the first question they always asked every time we went to see them was, who's taking medical responsibility for the patient? And as soon as Graham said I said it's the consultant geriatrician, they were fine. That's all they wanted to know, really. That and how to refer in.
Yeah, it's massively important to understand that, isn't it? Thank you so much. An incredible amount in that, and so many principles around starting small, rolling up, the development phase being massively important, the stakeholders that you involved, so much in there. Thank you. In terms of technology in the ward, what kind of technology are you using and how does it help?
I would probably say at the moment we're one of the low-tech hospital at home services. I think we've literally this month just started a point of care blood testing trial. I think we were, so the current system, and you may say this is very clunky and not very environmentally friendly, and that's why we are going for the point of care testing trial, was that the matrons would take a blood test as soon as they got to someone's house, call for a taxi, the taxi would go to the pathology lab, and the blood test would be processed within an hour, which is the same sort of standard as if somebody was in the emergency department. Clearly there's issues with that. Occasionally samples don't get processed, or there is a general delay. But I think we were, rightly or wrongly, I think we were a little bit reticent using point of care testing from the off, because we were worried about budget, getting the right machine. So, and talking to our pathology colleagues here at the Trust, I think they also wanted to have confidence in whichever machine we would start to use. So I appreciate that we are 3 years and a month or so old, and people might say, well, why haven't you done that sooner? But again, I think the pandemic didn't help us with that. I know that's an easy excuse to use, but I think, certainly within the next few months, I can see that being kind of established. And again, with regards to remote monitoring, I think as that remote monitoring ward has been sort of suggested by NHS England, we haven't started using remote monitoring, but I think there will be a cohort of our patients who potentially could use remote monitoring. Obviously, with an older population, you've got to make sure that the person's going to wear it and keep it on, and that's very much for an individual case-by-case basis. And I think that will probably help us save matron time, travel time, and there's hope for a sort of multi-specialty remote monitoring ward within Leeds, where I think some of our patients will join that. But the procurement of the actual kit is being done as a West Yorkshire wide, so I think that will probably be summer 2023 by the time that goes in. We were hoping to try and get a portable X-ray trial off the ground, but I think unfortunately our radiology colleagues, there's been issues with staffing, so that the example would be I don't think it would have been a immediate sort of, we need a chest X-ray today. It might have been a three-day a week service, but that I think maybe something for the future should again staffing be solved.
Thank you. There's some exciting things.
Yeah, we do
Sorry,
use
Angela.
the ECG app, don't we?
Yeah, oh, that's true. Yep.
Yeah. So
the ECB app.
ECG.
ECG.
So
sorry. Thank you.
To take a heart tracing, which is the matrons download to their mobile phone. Well, it's taken on their mobile phone and it's uploaded to so that the consultants can see it within the acute trust. I don't know whether you were seeing last night's panorama, and it looked very. Did you see it last night, Graham?
I didn't know.
So Oxford and Hull were on talking about their various models, and it all looked, so seamless. All the equipment, so they're using point of care testing, which Graham is correct in terms of we wanted to make sure we're doing the right thing, but the pandemic was the main reason. In the beginning, 3 years ago, we always had an ambition to have point of care testing. It's just the pandemic meant that the path lab people were completely and utterly prioritising all the COVID stuff. So that's why it got off track for a lot of time. But so in Oxford, they're using point of care testing, the ECG apps, but they also use ultrasound. So but they have a different model because they do have the geriatricians going out sometimes as well. So yeah, I think we're a low tech face-to-face hospital at home type virtual ward. So
although I would say in our defence, I think because we've been collecting the data, I think I think every trust around the country has suffered this winter with long waits in A&E, and I think we're still shown to be effective by saving around 22 beds a day since we've gone citywide. So so even if there are still high numbers, I think if we didn't have this service in Leeds, things would have been even worse. So I think you've got to, again, I'm not a Luddite. I think tech is useful. It's just, again, I think also there has been a bit of a case of making sure it's treating the budget as if it's our own money and not wanting to waste something on a bit of kit that might become obsolete in a few years or not get the support in 5 years or time, and you're just left with a load of stuff that you have to then buy again.
It's fantastic because you've showed that tech doesn't stop you. You've found ways of doing this that work for you with clear development plans. So I think there's nothing to apologise for. It sounds like a fantastic model with clear ways forward. So thank you. Clearly, you did a huge amount of stakeholder involvement and developed this model. How did you ensure that your service, and how are you ensuring that your service is accessible to as many people as possible within the community?
So I think when we did make use of the communications manager at LCH, and at that time it was a CCG, about really kind of spreading the word. So we, as I said earlier on, myself and Angela, we did a lot of face-to-face meetings, whether that was educational meetings, going to GP practices. But I think as we began to spread across the city, we used a different ways of communicating, whether that was sort of a very kind of factual text in an email. We also used videos, and as I say, face to face. We did start to do a video for GP practices for patients to sort of let them know what we were about. But I think we got to the final editing bit, and then COVID hit, and I think in a way that didn't stop us. So we've never really taken that up again. So we do on a weekly basis. We monitor our referrals, which GP practices are coming in, which hospital wards are referring in, how many from Yorkshire Ambulance Service as well. So as well as sort of ethnicity, age, and we will, whether people are in the care homes, or community rehabilitation beds, or their own home, there's no kind of limit on that. Yes, we have inclusion criteria, but that's kind of mainly based on our expertise as geriatricians. So initially we had an age cut-off of 70 years and above, but as NHS England sort of was kind of prompting us, we reduced that age cut-off to 65. And so we've always said our present capacity is around about 37 patients a day, and I know that sounds isn't a prime number, so it's a very odd number, but that's kind of working on some sort of how much time it takes to look after people on the ward. And our average, I think, caseload number is around about, low 30s, so 30, 31. But we have sometimes sprung all the way up to 50 when things have got a little bit, and that's got things a little bit hairy on occasions. But so I think we try our best to make sure it is accessible to everybody.
Angela, do you want to add anything from your perspective in there?
I suppose the only final thing to say is that as the word has spread within our own organisation, I'm talking about the community now, various services have, heard and thought, oh, so I'm giving examples, the fall service, the cardiac service. There is nobody excluded from referring into the virtual ward with frailty. The only thing we ask is that they have been seen face to face by a clinician. So, out of hours GPs, but our own services in particular, I think it's open to everybody. There's nobody who can't refer in.
And just kind of for information, could you just describe the referral process? Because it sounds like it's really simple. Is it as simple as it sounds?
So we have a single point of urgent referral in Leeds. So they're call handlers in effect, taking the calls in, and they patch the calls through to particularly from YAS, the external referrals, so the ambulance service, Yorkshire Ambulance Service, and GPs in particular, the main external referrers. They ring the single point of urgent referral, which is great for them because they just want one number, and then they are patched through to our clinical triage matron. They have a clinician to clinician discussion about the status of the patient, and a decision is made about whether it feels that patient may be appropriate for the virtual ward. The triage matron will accept or not. If they accept the referral, we're always very clear that it's an acceptance of the referral for an assessment of the patient to deem their suitability for the ward. After the assessment, the bloods are usually up, as Graham said, within 1 to 2 hours. It takes probably that long to assess the patient anyway. So by the time the assessment's complete, the bloods are usually there, and then a decision can be made either by the matron alone or in conversation with the consultant that's working that day covering the virtual ward about whether this patient can be cared for safely on the virtual ward, whether they're too unwell and they need hospital admission, or they're just not unwell enough and they don't even need that. They'd be signposted elsewhere. Once we accept that referral, then we take responsibility for what happens next. If they're deemed unsuitable for any reason, they don't go back to the referrer. We manage them onwards from there.
That's brilliant. Thank you so much. That's really helped me. And finally, it's been fantastic to hear about your development, what you've done, where you're at. What would be your 3 top tips for setting up a virtual ward from what you've learned so far? And bearing in mind, I can see you've already got plans to keep going and developing further.
So I think in no particular order, I'd certainly say you need time to set up the ward, and because as I said earlier on, between myself and Angela and Katie, there was, we had a lot of time to meet with people, to kind of have those meetings with various stakeholders. And I think trying to do something with one person with half a day a week, it's going to be very hard to set up a comprehensive service. So I think you do need to have that project management time from clinical and a project manager. I think I suppose the second one is accepting that it's not going to be perfect from the off, and just do it. And as Angela said, it's that whole PDSA, just reviewing what you're doing, learning from when times don't go right, but also kind of celebrating when things do. And I think, and sometimes it is easier to ask for forgiveness than permission. when you're trying to do things. I'm not saying that I use that throughout my, through my whole life, but I think when it comes to something like this, and I would give the example of, speaking to the team in Oxford about starting to use intravenous antibiotics, I think we possibly could have done that a little bit sooner than we have done. So I think if it's having that mantra, if it's right for the patients, it's the right thing to do. And the third thing I would say is just to collect data from the start, because in an age where you're trying to kind of prove that you're spending money wisely, that you're cost effective, but then it's not just trying to cover yourselves by making sure that you can prove that you're cost effective, but I think it's also seeing where you can improve, making sure that you are, which services you could use for, I mean, even things like, why is somebody referred onto the virtual ward if it's a lot of heart failure patients, which we do. That's why we've kind of started a lot, far more conversations with our community heart failure colleagues, and getting more education from them to try and help improve length of stay or onward referral. Equally, I think we're, for people who are suffering from delirium, we're starting to work more with our mental health colleagues as well. So I think it's data.
Thank you. Angela, would you add anything to those tips or any other ones?
Well, he's given 3, so if I'm allowed to sneak
you are allowed to sneak another couple in.
I said it at the beginning, and I say it every time, the pharmacists have been critical, in addition to the all-important geriatricians and community matrons. The pharmacist is critical. And I think we've benefited also from having the third sector involved, and certainly the night service, to avoid some of those hospital admissions for patients who wouldn't be safe at night. So
some critical partners there.
Yes.
Yeah.
Definitely.
It has been an absolute delight talking to you both, and there was so much within the conversation that I think people can reflect on and take away. So I'd really just like to thank you so much for taking time out today to speak to us. Be fascinating to come back and hear more in a year's time or a couple of years' time. But really just thank you very much for your time. Thank you for joining us, and hope people enjoy listening.